Good afternoon, everyone. On behalf of Oral Surgery Department, I, Dr. Vaishali Pagare, take an immense pleasure to welcome our chief guest, Dr. J.B. Garde, sir, our respected dean, Dr. Anand Shigli, sir, all the heads of department, all the staff and the student in the pledge of World Oral and Maxillofacial Surgery Day. I kindly request our dean, sir, and the Scientific Committee Chairman, Dr. Varsha ma'am, Dr. Rucha Gore ma'am, all the staff of oral surgery to please come on the stage to felicitate our chief guest, Dr. J.B. Garde, sir. I kindly request Dr. Vikram, sir, to felicitate our dean, sir. I kindly request Dr. Vikram, sir, to give welcome speech and introduce our guest speaker, Dr. Garde, sir.
Respected Chief Guest, Dean Dr. Anand Shigli sir, all heads of departments, faculty, staff, and my friends. We have all gathered here to celebrate the International Oral and Maxillofacial Surgery Day, which is celebrated the world over on the 13th of February every year. Friends, I don't know if you are aware, but this day, the 13th of February, it marks the birthday of a pioneer oral and maxillofacial surgeon, Dr. M.S.N. Jinwala, who was regarded as the father of Indian oral and maxillofacial surgery, and in his remembrance, this day was planned for our fellow oral and maxillofacial surgeons. Also, it is an opportunity for all of us to uplift our profession of oral and maxillofacial surgery and to highlight their role in different sections of our society, and we take this as an opportunity to highlight our role as oral surgeons amongst our own fraternity. Friends, today we have with us a very renowned and reputed oral and maxillofacial surgeon, Dr. J.B. Garde, sir. So please welcome Garde, sir, with an applause. Dr. J.B. Garde has been into exclusive practice of oral and maxillofacial surgery for the last 24 years. Sir has completed his graduation from Bharati Vidyapit Dental College, Pune in the year 1994, and he further went on to pursue his masters in oral and maxillofacial surgery, which he completed in the year 1998 from Rajiv Gandhi University's KLE Institute. Sir specializes in a host of deformities including trauma and pathologies. His main specialty of late during the COVID pandemic has been treating enormous cases of mucormycosis. Sir is attached to various hospitals within Pune, such as Pune Hospital and many of Ruby Hall Clinic and many other renowned hospitals. And he is also on the editorial board of the Journal of Oral and Maxillofacial Surgery. Sir is presently attached to M.A. Rangunwala Dental Institute, Pune as Professor, PG Guide and Head of the department. We are very obliged to you, sir, that you accepted our invitation today and have joined us here to enlighten us on the eve of International Oral and Maxillofacial Surgeons Day. Sir, I now call you upon stage to enlighten us with your bright words. Thank you.
A very good afternoon, one and all. Thank you so much, Vikram sir, for such a wonderful introduction to me. I hope everybody had lunch. Yes or no? Anand sir is going to give us snacks after this. Okay. First of all, I would like to thank sir for inviting me here. Anand sir has been my teacher way back 96. Sir was, and ma'am was also there. They have taught us during my post-graduation. And as sir said, I'm into academics as well as into private practice. So today's talk is going to be only clinical oriented. I'm not going to tell you any classification or nothing related to definition or anything. First of all, I address all HODs, postgraduate students and undergraduate students as my colleague friends because we are not together. Though we are separated by several branches, we work together. This is the college where I work, M.A. Rangunwala Dental College, where I work as a PG guide. These are the hospitals. Bharati Vidyapit Pioneer Batch, I have completed my BDS. Sir has also worked in Bharati Vidyapit as a principal in Sangli, and sir has taken that college to different level, and I'm really happy. Sir is here since last 4 years, and I can see changes over here. Phenomenal changes. Another institute where I did my post-graduation, Kelly's Institute of Dental Sciences, Belgaum. Sir was there, madam was there. And these are the various hospitals. Apart from these bigger hospitals, Ruby Hall Group and Pune Hospital, I am attached to several smaller hospitals, and I have been visiting to several dental clinics. So my backbone is all dental fraternity, not only hospitals and colleges. Now, if I tell you about dentistry, we all have heard when we were joining dentistry as only removal of the tooth and replacement of teeth. That's it. When I joined dentistry 89, I was unaware about anything else. Am I clear, sir? It's fine, sir. For me, it's fine. Am I audible? So these were the days where no anesthesia was there, nothing was there. Oral surgeons or dental surgeons used to do all the jobs. As we all know, I can say proudly, one of the dental surgeons invented local anesthesia. That you must be knowing. Friends, you all know change is the only thing which is constant in our uncertain world. Many of you must have not seen this phone, like we all are using now smartphones. So same is the technology. Look at the dental chairs, what we had before and now how things have changed. So in spite of several advances in field of dentistry or any other field, basic dental procedures in oral surgery are not changed. I'm yet to come across robot who is going to remove the tooth. Like we have a robotic surgeries for cancer, we have a robotic surgeries for abdomen, but in oral surgical procedures which connects you to all other branches, or all oral surgical procedures are trust building procedures in patient. Like you'll definitely agree with me, one painless extraction patient can send you at least 5 good patients, and one bad experience on dental chair with a painful extraction can block getting 10 patients to you. So it's a very trust building procedure. As I said, patients will never remember what you said, but they will definitely remember how you made them comfortable, how you made them feel on dental chair. And maxillofacial surgery or oral surgery is the only branch. I'm not underestimating other branches, but it's the branch which connects us or dental branches to other branches of allopathy, Unani, Ayurveda, or homeopathy. All other branches are there, but maxillofacial surgeons are working in the hospital. That doesn't mean all other doctors are not working in the hospital. We have, each and every hospital has got set up. Now coming towards the basic principles of surgery, I'm not going to teach you definition of asepsis. We all know everything about it. We are going to just see couple of procedures, what are their common and how they are important, and what is the role of maxillofacial surgeon or an oral surgeon in your daily routine, day-to-day practice in each and every branches. Let it be orthodontia, perio, prosto, pedo, or public health dentistry, how maxillofacial surgeon plays an important role or a vital role in connecting all other branches. Imagine this particular, I have put this slide as a one picture, but this was the slide where I had got this particular X-ray first. I didn't get clinical pictures. Why I have put this slide? Only looking at the X-ray, no one can come to the conclusion what patient is suffering or what you are going to do. This particular patient was referred to me for third molar removal. But with this mouth opening, can we remove this third molar? No. So thorough clinical examination is very important. For that you need to have a wide mouth opening. So don't look at only images, don't look at only teeth. You need to see surrounding, you need to see the environment, or not. Oral cavity is full of other organs also. You are supposed to look at the cheek mucosa, you are supposed to look at the tongue, you are supposed to look at the buccal mucosa. Everything is very important. So don't focus only on imaging. So what are the various minor surgical procedures one can do? Now one poor extraction, orthodontic poor extraction can spoil whole orthodontic treatment. So whenever you are doing any ortho extraction, support and forceps application is equally important. Now orthopedists will understand this, even interns will understand this. Never ever use elevators unless it is mandatory. Otherwise, deep grip with good support for ortho extraction is essential. Let it be lower upper tooth. I'm going with the basic how do the extraction. Look at the support of the jaw. Sorry. Then you have certain cases of orthodontic canine exposures. Are there any orthopedists here? Very good. You'll understand this. Let it be anywhere. Now, in these particular cases, not oral surgeon is going to perform the procedure. You have a combination. We have a periodontist, we have an orthodontist, we have a pedodontist, and oral surgeon. So it's a teamwork. Let it be anywhere. Now look at this frenums. Lingual frenum, buccal frenums. Even for the prosthetic purpose, if you are going for a complete denture, these frenums are equally important. Now this particular patient is dentulous. But if imagine this patient with without teeth, or a patient going for a complete denture, you cannot have a denture with such a high lingual frenum. So that is also surgical procedure which we do commonly before prosthodontic treatment. Then periodontal flap surgeries. As a dental surgeon, definitely you may not be doing, or you may not have a periodontist who is visiting you. But simple cases wherein simple curettage or simple flap surgeries one can do easily. You don't require every time specialist for these particular surgeries. So, role of oral surgeon in periodontal surgeries, you will say, what is the role of oral surgeon in periodontal surgeries? You can have a bone grafting, one can have a PRF grafting. So all these things come in a minor surgical procedures. Periodontics, first topic. Now, suppose you have a clinic next to school and suddenly you get a patient or a child wherein a child has undergone a trauma and teeth are avelled. You are not going to call oral surgeon, or oral surgeon may not be accessible, or he might take some time. But as a dental surgeon, you should be able to put these teeth back into the occlusion. Simple, do the endodontic treatment. You can do the endodontic treatment and you can splint them. What is the role of oral surgeon here? They can align this fractured jaw. It can be only teeth, it can be alveolar process. But as a dental surgeon, you should be well versed with these simple procedures wherein you don't require much of expertise. No doubt, the cases where there is a head injury, lot of bleeding, definitely these cases are going to walk into the hospitals where specialists will be called. But if you are clinic next to the school and you get such kind of patient, you should be able to manage such patients. Again, avulsion. Look at this particular patient. Patient is already delayed this treatment. Patient has come to us after 2 to 3 days. You cannot delay it further. But as a dental surgeon, one can do simple endodontic procedure. One can put this particular tooth back into the socket and we can splint it with the help of simple composite, or you can go ahead with the 24 gauge or 26 gauge wire. This doesn't require much rocket science. As a dental surgeon, you should be doing this. Imagine if you manage to do this kind of minor surgical procedures, you will be definitely getting a good number of patients referred by this particular patient. Yes, my doctor, my family dentist did this. He didn't refer me somewhere far up the hospital, or he didn't have to call a specialist. I am here to tell you what are the procedures as a dental surgeon one can do. Or cross faculty. I mean to say cross faculty, if you are a periodontist, you don't have to worry about such a smaller procedures. One can do these small procedures also. Endodontic procedures like simple apicotomies, where your gutta-percha point is beyond the apices, or you may have a smaller cyst at the apices of the tooth, and you may come across such kind of bleeding. Now, I am not here to scare you. Imagine a patient on a dental chair with such kind of bleeding. Don't panic. There is not a single vessel in the oral cavity which normal dental surgeon or a BDS person cannot stop that bleeding, unless patient is suffering from some or other severe medical issues. Or such kind of bleeding can be stopped only with the pressure packs, or if you have a cautery in the clinic. If you don't have cautery, in worst scenario, you can use your endo burnisher. I think Dr. Vikram will agree with me about this. I'll show you that picture again. So, such minor surgeries one can do. If a patient is going for a complete denture, for simple tori or a irregular ridge, you don't require to call oral surgeon for every time. You can take a simple incision, reflect. This will improve your surgical skill. In future, if you are going for implantology or if you are putting implants, this will definitely improve your surgical skill, and you can do simple alveolar with the help of simple burr or rongers. Then dental trauma we just spoke about. All these frenums, buccal frenum, lingual frenums, and many a time you tend to get such kind of lesions. What is this lesion? Epilis. Can you see this epilis? On the lower lip. Sorry, I jumped the slide. I'll go back. Sir, it's not going reverse. I think it's hang. Many times you tend to get, because of a cheek bite or lip bite, such kind of lesions on the lower lip. Even for these particular smaller lesions, as any speciality, you can be periodontist or periodontist, you can do this particular surgery. What happened? You can put a charger. Only thing you should know how to hold the blade, 15 number blade. Need not to go deeper. Take a simple mucosal incision. These particular incisions, if you learn well in your perio or in your oral surgical procedure, very easy. Again, I repeat, there are no important blood vessels which will definitely create a panicky. One can easily stop this kind of bleeding. So this is a simple epilis removal. Even normal BDS person can do this particular surgery. Epilis. You'll come across such kind of cases in your clinic, and every time it's not possible to call oral surgeon for this. So this is not working. There is a problem with it. Yeah, now it's. Then simple third molars, I'm not telling you to do all difficult third molars. Simple third molars one can do. Elevation extraction, you should be careful about luxating the tooth. A simple elevation techniques you can learn. You have an excellent oral surgery department. They will teach you about how to elevate the tooth, what kind of breath one should take, how deep you should go. So every extraction one should go deeper beyond the cervical level of the tooth, and then compress sockets nicely. You may be going for implant, patient may be going for implant, so compression of the socket is equally important. So that's the forceps extraction which we saw. Deeper roots, such kind of simple roots, you're not going to call oral surgeon every time. Third year BD students, final year BD students, don't get panicky with such kind of teeth. Definitely in intensive you'll get few such kind of teeth, and maybe after completion of the course you will be able to do these particular extractions in a couple of trusts, or maybe you will be visiting some poor hospitals where you get good number of patients. So you should be able to do this extraction. Suppose you have to put implant for this particular patient, immediate implant. It's not possible to call for each and every case a oral surgeon. A patient will keep on thinking, doctor is unable to remove simple tooth. Why is he calling oral surgeon for implant? So I might as well go to somebody else who will remove the tooth. So here I am telling you the simple methods of doing extraction. Now, these are the tricky teeth where all should be careful. Where you have vertically fractured teeth, you should tell patient this particular tooth will take time. Not necessary this particular tooth will come out in 2 minutes, 3 minutes. Vertically fractured teeth are difficult to remove. You must inform patient prior. This is a fractured tooth. It's not possible to grasp it properly with the help of forceps. So patient will start comparing your procedure with some adjacent dentist. That adjacent dentist removed my tooth in 5 minutes. So there is nothing wrong in your technique or your skill. You are doing it proper. So each and every extraction, let it be extraction or a minor surgical procedure, never tell patient this will take 5 minutes, 10 minutes. Tell them we are doing automatically. Every extraction is difficult. It may take little more time. That's very important. Now, as you all know, we are coming with several pathologic lesions in the oral cavity. Simple swelling in the oral cavity. Every time it's not possible to refer to the specialist. As a dental surgeon or a cross faculty, maybe any other faculty, you should be able to aspirate this. It's a simple fine needle aspiration biopsy, wherein key point here is don't use your routine injecting needle. If you are using your routine injecting needle, that 26 or 27 gauge needle, you will not get aspiration. So you need to use a wide bore needle, maybe 20 or 22 gauge needle. That you need to keep it in mind. If I'm sure you are not going to treat this patient, but patient will definitely have very good faith in you. Doctor has diagnosed my particular pathology. Let it be cyst or abscess or tumor, and this particular dental surgeon has guided me to the specialist. So that's very important. They will remember you as a family dentist. So though you are not going to do major surgery, you should be able to do simple biopsies. It can be simple incisional biopsy like this, wherein you can come across white patches of leukoplakia or lichen planus, or it can be CA in situ, or it can be simple varicose carcinoma. Every time it is not possible to send this particular patient to the specialist. As a dental surgeon, you are capable of doing these biopsies, wherein you don't require much expertise, you don't require any sophisticated instrument. If you have a laser, well and good, but every biopsy you don't require laser. Simple 15 number blade is more than sufficient to take these particular biopsies. Only thing, you should not go deeper. You should take a normal periphery of the mucosa as well, and you should be able to suture these particular lesions back, and this particular tissue should be sent to the oral pathologist in 10% formalin. Since last 4 years, I am sending all my oral pathology tissues, all tissues to the oral pathologists. They are better in differentiating all the tumors. Let it be ameloblastoma. General pathology will say it's only ameloblastoma. Our colleagues, our fellow colleagues will tell you which variety of ameloblastoma it is, which variety of keratosis it is, whether it is a parakeratinitis or orthokeratinitis. So you should bring our colleagues up rather than sending it to the histopathologist who is a general pathologist. I have my own oral pathologist, and I get my all flights confirmed, and I send my all oral pathology tissue to oral pathology department as well as the oral pathologist. So as a dental surgeon, you should send all these tissues to oral pathologists. Then nowadays we are getting lot of tongue lesions also. Many times because of cheek bite. Now this particular picture I have video, I have purposely kept it here. Patient had gone for dental treatment, and this particular lesion was noticed by a dentist. Imagine any other person will notice this lesion. By the time this particular patient will come to know he is having a CA or a squamous cell carcinoma in the oral cavity, it will cross midline. Imagine, patient has to do most of the tongue. So my sincere advice here, whenever patient comes to you with any tooth pain also, don't forget to examine thoroughly oral cavity. Simple tonsillar pillars, buccal mucosa, tongue, lower lip, upper lip. So it doesn't take more than 2 minutes. You need to examine this. And such smaller lesions, you need to warn the patient. This particular patient can walk into any of the dental clinic with simple soreness in the mouth or sharp teeth, sharp dentures. These are the lesions which create these particular problems. So as a dental surgeons, most of the oral pathological lesions, including squamous cell carcinomas, are going to come to dental surgeons. Battery is low, right? I'm unable to go forward. Now, many patients are diabetic. Here, my sincere advice to each and every students, third year, final year, and interns. Many patients are diabetic. You have to be choosy in giving antibiotic. You need to take a proper case history. Now, this particular patient was diabetic. A doctor opened a root canal for this particular patient previous night, and second day morning patient came back with such huge swelling. When we did a blood sugar level, it was 420. Imagine such a high sugar. You have put the patient only on amoxicillin. I think most of us believe in only in amoxicillin. We don't go beyond that. Though we have read about pharmacology, there are many more wonderful drugs, but we always believe in amox. But it doesn't work in such kind of infection. Now, patient is going to same dentist. Doctor has opened my root canal, and I got a first. But it's patient's fault also. Doctor also didn't have the history. Patient also didn't do the history. So spend some time in taking a proper case history, wherein ask patient, are you suffering from hypertension, diabetes, or are you taking any other medication for any other systemic problem? Let it be thyroid, or some patients are on chemotherapy medication. It doesn't take more than 2 to 3 minutes. By asking these questions in a simpler manner, you build up some rapport. You always have some rapport with the patient. Patient starts feeling that doctor is concerned about me. Don't treat patients oral cavity only. Remember, oral cavity is in a patient's body. So you have to consider patient as a whole, not only oral cavity. Think about whole system, cardiovascular system, respiratory system. Even a simple asthmatic patient, If you give a brufen to the patient, patient can have a severe anaphylactic shock because of the brufen. So you need to ask patient what kind of problem you are suffering from. Diabetic patient, if you have given a corticosteroid tablet for lichen planus, and if you are unaware of the diabetes, patient's blood sugar level will shoot up very high. In some cases where you need to require a specialist, like these cases, don't attempt such kind of cases on a dental chair. You need to send this patient to the specialist. This is a Ludwig's angina case. It has nothing to do with the third year or fourth year students. But remember, you tend to get a full question for a Ludwig's angina where you require incision and drainage. Imagine this Ludwig's angina is not because of any other problem, but because of the dental infection. Many patients, almost 90% patients will have such kind of Ludwig's angina because of dental problem, and where there is a severe pus formation within the patient's spaces, and this is a medical emergency. So any patient walking in your clinic with swelling and you are unaware about patient's history, need to examine this patient thoroughly. You have to consider this as a medical emergency. Patient can die with a Ludwig's angina with a respiratory arrest. There are very few medical emergencies which one can come across. One of them is anaphylactic, other one is Ludwig's angina. In spite of recent advances in anesthesia, many patients die because of Ludwig's angina. So dental surgeons have to be very careful. Now, everybody, important topic here, money minting business, implants. Everybody wants to earn. So simple indirect sinus lifts, where you are going to put the implants. As a dental surgeon, we can do it easily. You don't require to be a specialist implantologist, or you don't require to be oral surgeon. One can watch any oral surgeon or a periodontist or a prosthodontist doing few sinus lifts, and one can easily do these sinus lift surgeries. Even sinus lift surgeries, direct sinus lift surgeries with bone graft, I know many dental surgeons, BDS dental surgeons, they are doing fantastically. So each and every case, one can train yourself and do it. These are money minting cases wherein you need not to send them to others. Dentistry is very wide. No, it's not only smile designing, it's not only endodontic treatment, it's not only periodontic treatment. There are many more things one can do in dentistry. Then difficult cases like this, where you have a very less space for the implant to go. If you are trained well in implantology, one can put implants in such narrow spaces also. So train yourself, work with the people, and as a dental surgeon, one can do any implants. Like orthodontists are doing nice implants for ortho cases. You don't require oral surgeons for that. Then larger cyst, I know your role is over here. You are going to diagnose it, as well as you are going to guide the patient. Now, as a dental fraternity, you can see this particular case. Why I am putting this particular case here? See, this particular case had gone to the plastic surgeon. I am not here to criticize any branches. Plastic surgeon advised to go for a resection of the jaw, lower jaw, from one side third molar to other side third molar. Now, as a dental surgeon, you should know this particular lesion is a keratosis. You should be able to diagnose, and there is a way, or there is another method wherein one can manage these cases with a simple conservative management, decompression, which fourth year students must be aware, interns must be aware, wherein we reduce the size of the lesion and one can easily save the teeth also. Look at this particular teeth. Now, as a BDS, what is your role? Diagnose and guide the patient. Otherwise, what will happen? Other branches like orthopedic and plastic surgeons, they will simply resect this particular jaw and they'll put prefibular graft or and bone graft and maybe implants. I know that is not wrong, but as a dental surgeon, what you have achieved here, you have saved patient's jaw, you have saved patient's bone, and as well as you have saved couple of teeth of the patient. So patient will definitely remember you throughout life. Yes, doctor has saved my jaw. So that's a keratosis, large keratosis wherein we had gone for a conservative management. And again, this is getting blocked. Yeah. Okay, fine. This is the conservative management of the keratosis. I'm not going to go in details of surgical management. As a dental surgeon, don't attempt such difficult third molars. You have your colleagues, oral surgeon colleagues to do it. please don't attempt such third molar, deeper third molars. So do's and don'ts you can understand. As a dental surgeon, you can come across various bleeding from uncontrolled bleeding from extraction socket. Now you will understand why there is a bleeding from throat. One doctor, dental surgeon, did an implant in the anterior region, central incisors, and while doing implant drilling, they perforated nasal floor, and patient was bleeding from throat. There was a nasal bleeding. So this particular job will be done by an oral surgeon, wherein you require nasal packing. You don't have to send this patient to the hospital. You can perforate nasal floor, and one can have a severe bleeding. Such bleedings can be managed with the help of simple cautery, or we have several surgical or topical methods, wherein you have Abgel, bone wax, Surgicel, Botraclot. Definitely your surgical department will teach you. Then we have systemic hemostatic agents. Not only in oral surgery clinic, each and every dental clinic should have all these topical and systemic hemostatic agents. We are in an era of most of the patients with the medically compromised, they are coming. Every third or fourth patient is taking ecosprin. Some or other day you are going to come across these bleeding emergencies. Don't attempt such cases. You need to inform the patient about adjacent tooth. If you are doing a third molar, look at the adjacent tooth. One can damage adjacent tooth, or it's already damaged. So these things are very important. One can displace third molars into the lingual pouch or lingual side of the mandible. So these are the cases where you require expertise. Patient can aspirate the tooth. These are the common complications one can come across. Look at the tooth, where is it? Even your implant instruments can go into the chest. Yes, it has happened with me also. Suddenly patient swallowed the implant dry. It can happen. Patient can swallow tooth also. So this can come across. Have a good rapport with the adjacent radiologist. Have a good rapport with some maybe a chest specialist. If such things happen, one can retrieve them. This is one of the complications. It is not a blunder. Don't think it is a blunder. It can happen with anybody. Oh. So bleeding. Extraction socket, we have already seen. Aspirates of the tooth. Which now another factor or another area where we are always scared, maxillary sinus. Imagine this is a harmless cavity. Nothing. If you are within the cavity, nothing happens. On the top, you have an orbital floor. On the side, you have a lateral wall and posterior wall. If you are within the cavity, nothing happens. Even your tooth displaces in the maxillary sinus, don't get panicky. It's a common complication which we do come across. It does happen, especially endodontically treated teeth, or where there is a periapical lesion. Such root can go into the maxillary sinus. If you are not competent enough, you can call oral surgeon and they will do it. But inform patient. There is a tooth or a root which has gone into the sinus because of the weakness of the bone. It can happen to anybody. I have displaced many teeth in a maxillary sinus as an oral surgeon also. It's not your fault. There can be erosion of the bone because of the infection or many other reasons. You should be able to retrieve this. Tuberosity fracture is very common. 1 out of 100 third molars, maxillary third molars, one can come across tuberosity fracture. How to manage that? You should be able to compress it properly. You should be able to suture it. One can have oral-antral communication when your tuberosity is fractured. So ensure, all dental surgeons, you should ensure there is no bubbles or there is no signs of oral-antral communication. I'm not going to go in details of each and every science, but simple, there can be nasal regurgitation, patient will have problem in talking, patient will have problem in sucking the fluid and bad breath. These are the simple signs of oral-antral fistula and communication. You should be able to diagnose this as a dental surgeon. Yeah. So it's going forward here, but it's not going there. Yeah. Now, implants. Implants can displace into maxillary sinus as well. I have retrieved more than 15 implants from maxillary sinus. So you should be careful. Any implant, whatever implant you are doing in a maxillary region, it should be visible. And one more clinical advice, osteotomy should be smaller for maxilla. For mandible, being a cortical bone, you can reach to the whatever size they have advised companies. Suppose you are putting a 4.5 implant, you can widen it till the 4.3. But in maxilla, you need not to widen this. And whenever you are putting implant in a posterior region where there is a sinus floor has come down, one has to be really careful. Otherwise, one can have a perforation of the maxillary sinus floor and implant can go into the maxillary sinus. Don't get panicky. It can be easily removed from the buccal aspect. Then tooth in the maxillary sinus is again a common complication any dental surgeon can come across. It can be easily retrieved with the help of buccal advancement flap. Tuberosity fracture, we have already discussed about it. I am just keeping this slide. Angle of the mandible fracture, if you have not removed sufficient bone, one should know how much bone to be removed. Imagine this particular case where there is a osteomyelitis. So just don't go on digging the bone. You need to read the x-rays properly. Bone belongs to patient. It's not yours. So use it or remove it very carefully. For this you require an oral surgeon where one can do the bone plating at the angle of the mandible. It can be done under local anesthesia. Look at the third molar which is impacted. Some dental surgeon tried to remove the tooth without removing sufficient bone. So unless you are trained enough to remove such deep-seated third molars, don't attempt that. You have an oral surgeon. That is where oral surgeon's role is. Or where deeper seated third molars, one can see the inferior canal. Such patients, one can tell in the beginning itself, this particular patient might land up with the numbness of the lower lip. Imagine this is the inferior canal, tooth was deep seated over there. One can see the inferior now here. So one can have an exposure of the inferior now. So need not to cut it. For these particular cases, you need to have an expert like oral surgeons. Dislocation of the jaw is a common condition which everybody experiences in a dental clinic. One should be able to put it back into the condylar head into the socket where it can happen in a closer patient or a patient who is sitting in a OPD. One can go into the dislocation. Simple procedure, you can learn it from any oral surgeon. You don't require experts for all these cases. Suppose dislocation is left untreated for more than 12 hours, 24 hours. In such cases, you require to have a general anesthesia. Otherwise, normal dislocations, one can treat them on an OPD basis. You don't require general anesthesia. Breakage of instrument, you can remove them. It can be burr, it can be instrument, it can be elevator. Implant displaced into the lingual pouch. Whenever you are learning implantology, remember mandible has got a curvature, wherein there is a lingual curvature, there is a mylohyoid ridge. You tend to perforate mylohyoid ridge and you tend to go into the lingual pouch. Imagine this implant has gone into the neck and we had to remove this implant from the extraoral approach under general anesthesia. It can happen. I'm not scaring you. These are the few complications. It's like a road traffic accident where you don't follow rules and regulations or somebody doesn't follow the rules and regulations. One can come across accident. If you're traveling, then and then only you'll come across accident. If you're not traveling, you'll not come across accident. So only because there are several complications in oral surgery, you should not get scared to do these cases. Yes, it can happen to anybody. Complications are part and parcel of your routine dentistry. Now, one more thing I want to tell you, all of you, nowadays, like many dental clinics I have seen, they use cotton for the reflection of the mucosa or in a routine procedure. This is your cotton. Now, look at this particular case. One dental surgeon attempted to remove this third molar and by mistake, he displaced cotton within the lingual pouch. It went deep into the lingual pouch, almost till the mylohyoid muscle. And he was unable to retrieve it. So always use gauze instead of cotton. If you are putting a gauze, you can hold it with the help of any instrument or gauze is easy to retrieve. And apart from retrieval, cotton can leave lot of fibers behind. Look at this fiber and that can create a post-operative infection. So in oral surgery, where you are opening the flap, let it be for anything, let it be simple pedo procedure, you have to use gauze, preferably saline soap. Vikram sir will agree with me. Cotton doesn't have role in reflecting. Yes, cotton you can use it for endodontic procedure where you are using cotton rolls. But oral surgical procedures don't use cotton. Many clinics I have seen people do use cotton nowadays also. Now this is an interesting case. Why I'm putting it here? This particular case came to us 3 years back. Look at this. Now this was referred to me by a pedo department. We did it in pedo department. I am putting all the X-rays together here. Now how interdisciplinary approach is very important. How oral surgery or all other branches are interconnected to each other, I'll tell you. Look at this. You'll understand there is an impacted canine here. You'll understand there is one impacted canine here. Fine. There is a lesion here. We did a simple biopsy. It was a keratosis. Now, being a keratosis at 2 places, we diagnose it as a Golingos syndrome. I think third year students, fourth year students and interns, you must have heard about Golingos syndrome, where there are multiple oral keratosis. Now, instead of removing the tooth, what we did, we put a decompression tube here. We removed the impacted tooth. We put a decompression tube over here. We got the third, this canine down. Look at the canine where it is now within 2 years. Why I'm showing this? This is possible in your clinic. It doesn't require any experts. See, look at this canine. Look at this lesion. This lesion is gone now. But in these 2 years, because of the follow-up, we have come across one more important lesion. Now look at this third molars. Look at this upper third molar. See now, lower, this third molar was here. Third molar is here. Instead of coming down, it went up. Why it went up? There are cyst developments over there. Now, in all 4 quadrants, there is a cyst development. It's a Golingos syndrome. You must have come across. Now, only oral surgeon is going to treat this? No. Because this particular case was diagnosed by a pedodontist, then it was treated by an orthodontist for this particular tooth to be brought down. Then it was treated by an oral surgeon, then perio. So it's a teamwork. Only one person is not going to do it. So don't send these patients directly to the specialist. Your role is also equally important. Now, why I said any pathology, whatever comes to you, or maybe you have referred it to any other doctor, ask patient to come for thorough follow-ups. In spite of this patient coming to the orthopedic department, they didn't bother here. Then because of the lockdown, patient didn't take X-ray for 1 year, and suddenly patient came to us last week and we realized patient is developing cysts all over. What is important here? Periodic X-rays. In cases where you come across the unusual pathologies like keratosis or patients suffering from some syndromes. Now this is also possible. Why it is possible? Only because of my ortho colleagues. Previously what we used to do, we used to cut the jaw, bring it forward and put plates and screws. My orthodontic colleagues, what they have done here, look at this. This case is done just a few days back. I'm showing it to you only to have what is possible as a team. Imagine cleft palate with retrographic maxilla, where maxilla is 12 to 13 millimeter behind. My orthodontic colleague, Dr. Leni, who happens to be professor over here, he has put this particular appliance, and ortho PCs will understand this appliance. Usually we use it for expansion of buccal expansion, but we have done a anterior-posterior expansion here. Look at this. We did a simple maxillary osteotomy, and look at this appliance. Ortho PCs is very important for you. I'll forward you the article. There are very few cases in the literature where there is a cleft and there is such a deficient maxilla, and we went for a advancement of this particular maxilla. I'll go back again. You'll understand what is the result. This case is going on. Look at the result. Look at the advancement. Within 10 days, every day 1 ton, that's a distraction osteogenesis. You must have heard about distraction. Wherein what I have used here, simple orthodontic appliance. Is it possible for me to construct this appliance? No. My ortho colleague has done this appliance. And look at the patient's this thing. Now, patient will go for a rhinoplasty and secondary correction. With endodontic treatment, patient will go for endo treatment. Patient will go for implants, prosto treatment. So it's a team approach. Not only one branches. Suppose you are doing PG in ortho, oral surgery, perio, but you need to be in a connection with all other branches. Don't focus only in your branch. You can have such cross connections. Again, another case. Look at the lesion. This particular case came to me 1.5 years back. I'm just telling you, these patients are not come to me directly. They are referred to me by dental surgeons. Definitely, patient has toothache and patient has gone to the normal dentist and patient was having pain here. Patient 6 and 7 were paining. And I took a OPG. Imagine the third molar where it is. Patient is just 12-year-old girl. And Sassoon doctor, government doctor had advised her to go for a resection of the jaw and a prefibular graft. Imagine a patient with a 12-year-old girl going for a resection of the jaw and putting a prefibular graft. How traumatic it will be. As a dental surgeon, as a clinician, we can do wonders in such cases. I am not boosting myself in this particular case. Since patient was cooperative, we put a decompression tube, and this particular case was managed under only local anesthesia. Even a third molar was removed under local anesthesia. You can see the patient's eyes open. This patient came to me during the pandemic where it was not possible to take them to the hospital and patient was extremely poor. In this particular patient, I have not charged any money, though I just took 12,000 from the patient and every month I was giving her back 1,000 rupees for the OPG and coming going. Every time money is not everything. This, you need to do something. Some cases you are bound to have, we are bound to give something to the society. That will definitely give a lot of pleasure. Now this, look at the case within 1 year and 13 months. Look at the lesion now. This is completely gone. We have done an endodontic treatment. This lesion was ameloblastoma, follicular ameloblastoma. Now, what we had heard from Laskins and all other Peterson books, any ameloblastoma, resect it, graft it. But as a dental surgeon or a BD student, you need to try conservative treatment. Even this particular lesion recurs after 12 years or 10 years. I am going to follow this. I can have a nice lower border of mandible and I can give a good aesthetic to the patient. This is where role of the oral surgeon is. So you have contact with good oral surgeons and do these cases in conjunction with the oral surgeon. Definitely patient will give a lot of blessings to you. Now another ameloblastoma. Now what is your role here? You can do endodontic treatment, you can do crown and bridge. If plastic surgeon resects the jaw, patient is not going to come to you. Patient will go to the implantologist and prosthodontist. But one can go ahead with the decompression of such cases as well. So don't believe only in a theoretical knowledge. Look at this particular case, completely done under local anesthesia, where I didn't go for a hospital. We did an endodontic treatment, though we removed couple of trees. So this is possible. Now such cases, sir will understand. We are going to come to you. Now we are in fix. Now we are going to have a higher technology. I'm coming to it. Wherein, look at the teeth. There is hardly any tooth support here. There is no roots. There are no roots. So here, I'm not the only person who is going to treat this patient. I need a psychiatrist, I need a periodontist, I need a endodontist, I need a periodontist, I need a prosthodontist. All. It's a teamwork which patient is going to be benefited with. I need a nutrition specialist also. Now, various impacted canines, ortho exposures or such teeth removal. Again, many people will scare you. If you take an incision on a palate, you will land up with a severe bleeding. No. If you are within the periosteum, such deep-seated teeth also can be removed under local anesthesia. Look at this particular tooth. It was in the midline. Look at the healing within 10 days. One can take incisions on the palate, not across. You can reflect palatal mucosa from one side, third molar to third molar. Only hurdle will be your posterior artery, genital artery. Otherwise, you may not have any problem. So don't worry about bleeding part. As a dental surgeon, one can do simple minor surgical procedures easily. They are very daily routine procedures. Now, sir, as sir said, mucormycosis. There were cases who had gone to the dental surgeons wherein, in spite of having such a pustules, now periodontist role is there. In spite of having a mobile jaw, people had opened root canals. Happening. It's not their fault. Mucormycosis was not new. It was there. We treated a couple of cases. In my 24 years of experience, I had treated only 4 cases. In the last 1 year, I have treated more than 100 cases. Mucormycosis, where we have to remove part of the jaw, zygoma, maxillary sinus, in some cases even bilateral maxillectomy. Now, here is again a team approach. Now, once I remove the jaw, who is going to reconstruct that? My colleagues from prosthodontists, my colleagues from endodontists, remaining teeth, they will be doing endodontic treatment. Look at this. I'm going to fast forward these cases. So, mucormycosis cases, now they are coming for the reconstruction. Initially we did an opturator, now we are going for a 3D printed technology. One more case, you must have read it in a literature, or Eagle syndrome. This particular patient was rushing from one dentist to other dentist. Patient came back to me, came to me from Nagpur. Nobody realized why patient is getting bilateral pain. Now we have heard about Eagle syndrome. We have such an excellent technology. Now we can have a CBCT. Look at the styloid braces, how elongated it is. Now who is going to operate that? Not ENT surgeons, your colleague oral surgeons. But who is going to diagnose? As a dental surgeon. The Eagle syndrome, wherein I have resected the patient's styloid braces. It was more than 52 millimeter. Normal is around 20 to 25 millimeter. And last year we got three cases. So unexplained pain where think about something out of the box. Now TMJ problems, we can have TMJ problems because of prosthetic problem or internal treatment problem or a psychological problem. One can do the orthocentesis, your oral medicine pieces can do orthocentesis, proto pieces can do orthocentesis. It's a simple procedure. One can we will have a, with sir's permission, we can have a small workshop on TMJ itself. This is because it's not possible to cover everything in one lecture. Well, just give me 10 minutes. I know you all are hungry. Orthocentesis can be possible. Now, even trigeminal neuralgia, where are they going to go? Dental surgeons. I have couple of cases wherein people have removed complete teeth. Again, my laptop is, sorry. Am I? Go back. Only few slides. Am I too slow? That's fine. No, sir. There was one more case. I think one slide got skipped. Anyway, trigeminal neuralgia, you all know about it. You have studied it from the second year. Now, this is the case. You will say why I am putting this particular case. Now, my prosthodontic colleagues and endodontist colleagues have done a wonderful job for rehabilitation of this particular case. Maxillofacial trauma, wherein look at the shattered teeth. No other faculty in other medicine, plastic surgeon, orthopedic surgeon, or an ENT surgeon, they cannot do this reconstruction. Only we together can do this particular reconstruction of this particular jaw. Nose, look at the different. Now how teeth are aligned, look at the bone plates and screws. Now these remaining teeth have undergone endodontic treatment. Now we are putting couple of implants. Patient is going for a rhinoplasty. Yes, it's all possible. Dentist is not only removal of the tooth and putting the gatapacha and composite and this thing. So you are in a fantastic, excellent profession where you can do so many things. Every clinic, let it be perio, ortho, oral pathology, should be well equipped with this. Now DCI norm says you should have all these equipments, including oxygen cylinder. I do come across clinics where there is no oxygen cylinder, there are no this thing. Now you will say, is it required? Now every car comes with the airbags. How many times you require airbags? Hardly. When you are prepared for emergencies, emergencies don't come. Like that's a statement from many medical emergency books, Monims as well as Stanley Malamed. So one should have mandatory. There are incidences. I am not going to name the doctors. Last year there were 2 incidences where patients died in a dental clinic where doctor or law or court didn't ask them why patient died. So what the court asked, whether that particular doctor was having any emergency equipment to manage such kind of medical emergencies. Whether you know how to use them or not, it's mandatory to have this particular medical emergency kit. I'm not going to go in details of medical emergencies. We can have a separate workshop on medical emergencies with all other departments. One can have all these medical emergency drugs that only 20 to 25. Again, one can have this particular medical emergency equipments, endotracheal tubes, mask, that's a must. Now I'm coming towards the prosthetic part. Wonderful job my prosto colleagues, doctor, are doing. Look at this 3D crafted. Imagine now we have so many things available. One can give just patients CT scan and one will get such a nice prosthesis. Even poor reach, where 1 millimeter bone is there, I can go for a prosthesis. Why not use technology? surgeries have come in surgery. So same is here. We have 3D printed technology. Even resected small part of the jaw can be reconstructed. Again, it's a teamwork. Whole maxilla, which has been removed, can be put back. One can give patient smile back. I'm sure I'm not going to do this. My prosto colleagues are going to go to. Look at this patient. He's smiling. Patient has started eating now. With the help of all of us. My job is to resect it. But reconstruction, definitely my other colleagues are going to do it. Mucormycosis, post-COVID, obturator, prostocolix, then half of the maxilla, full maxilla. Imagine, in this particular patient did had even soft palate. Now we are going to go for grafting. 4 implants, 3D printed. The patient has started eating. All this is possible. Why not? Now technology is there. Why not use it? Suppose, now I am coming to the few slides. Today only I got a call for fracture of the jaw of the dog. Do something like this. You may have a habit of playing some instrument. Give something back to the society. You will definitely feel good. I'm sure this particular cat is not going to pay me or this for this fracture mandible. But imagine she started eating on the same day when I did the fracture reduction and fixation. Why not apply your knowledge to the cross branches? I must have treated more than 15 cats and dogs for fracture mandibles. One of the renowned veterinary surgeon from Pune keeps on calling for me for that case. Monday I'll be having one case. Anybody can join. Dog fracture is there. So you great later. You will be renowned. You may get publicity. You can put it on social media. That's the way how it works. Don't get into the only 4 blocks of the dentistry. Come out of it. Do something different. That's really important. See, look at the fracture of the lower jaw. Who is going to treat that? Unfortunately, our veterinary people are not trained in this. They say we just put a plaster. Now we know principles of plating. Why not apply it over there? Now I'm again coming back to these X-rays. I'm coming to the last slide, almost last slide. Now these cases are not come to me directly. They have been referred to me by my all dental colleagues. Maybe normal dental surgeons, periodontists, orthodontists, or a periodontist. Because they spotted these lesions and they came to me and patient could get a proper treatment. So, who is my backbone in practice? We are. So, we need to help each other. We are the one who are referring to the patient to the specialist. These all cases are going to walk into you. Different pathologies. You cannot cross-refer them to plastic surgeon or a ENT surgeon or an orthopedic surgeon. Our colleagues are doing better job. We are well trained. We are well skilled. Like you are my backbones in my personal practice. See, here is my backbone and heart, my daughter. She's also in dentistry, and that's my family. Should be your spinal cord, heart, or backbone. Because of them, we can do anything and everything. Without family support, one cannot do. And you have to work together. Only as a team one can achieve this goal. So dentistry, as I said, is not restricted to one branch. Oral surgeons, I know people say oral surgeons have a lot of ego. They are not helpful. They are not down to earth. They are very arrogant. It does apply to few of them. But if it has to come to me, you can contact me anytime for any complication. And I thank Anand sir for calling me for such a wonderful occasion. Sir has been my teacher, and thank you for the patient listening. I'm sorry for the interruption in between. Thank you so much. Field, we have several slides. With search permission, we have several workshops here. One on medical emergency, one on medical emergency equipment, drugs, and we have one TLA, and we have excellent infrastructure. I think it's one of the best institutes in India now. When I walked in here, I thought I am somewhere in Singapore or Dubai.
anyone has any questions, they can ask right now. Teachers or students, anyone. Please raise your hand if you have any questions.
Simply raise your hand. Anyone has any questions, simply raise your hand. It's that easy. Sir has made so many things easy for us today. Huh? As easy as raising your hand. Sir, thank you for that wonderful presentation. So the topic for the day was role of oral surgeon in dentistry. But sir, you have gone much beyond that, and you have also highlighted the role of the dentist in oral and maxillofacial surgery. And that was something that was really a wonderful effort taken by you. The do's, the don'ts by the general dentist, and more than the don'ts, what the general dentist can do to contribute to oral and maxillofacial surgery, that is what sir has highlighted. And much more than that, he's provided us with a humane approach. Like when we think of oral surgery, we think it is just about cutting and scalpel and needles. But sir has gone beyond that and showed us the humanitarian path, right? So thank you so much, sir, once again for those words of wisdom and enlightenment. Now we'll have the vote of thanks. Before that, I would like to make one announcement. Dear staff, we have all arranged for you refreshments in Department of Oral Surgery. So after the vote of thanks, everybody, please, all head of departments and staff, please join us in our celebration in Oral Surgery Department. I now call upon stage Dr. Pratik Hande to deliver the vote of thanks.
So 2 take-home points for today. We need to give back to society and we need to work as a team. Okay. So I take this opportunity to thank our speaker for today and chief guest, Dr. J.B. Garde sir, for a wonderful speech, and especially he has given his precious time to us. Secondly, I would like to thank our respected Dean, Dr. Anand Shigli sir, for providing all the help, permission and support for this program. I would like to thank the Department of Oral Surgery, our HOD Dr. Vikram sir, Kapil sir, and Dr. Vaishali for their constant support. I would like to specially thank the scientific committee headed by Dr. Varsha Mirani and the organizing committee of the campus for giving all the support and help for today's program. I would like to thank the office staff, CS Patil sir, Vijay Bhave sir, Mangesh Patil sir, for their untiring support. And special mention to our interns, Aditya and Ashwin, because they have worked very hard for today's program. Lastly, I would like to thank the HODs of all the departments, all the staff, the students and interns for today's program. Now I declare this program to be over. I would request all the staff to head towards the Department of Oral Surgery for refreshment. And thank you, students.